Hi, good evening, everybody. So are my slides visible? Yes, fantastic. Okay, so my topic for today is selection of first-line therapy for MET amplification and MET exon 14 mutation in NSCLC. As we very well know that NSCLC harbors mutations, a lot of which now are actionable. MET exon 14 comprises around 3% of these mutations in non-squamous. And this is basically a proto-oncogene present on long arm of human chromosome 7, which encodes the tyrosine kinase receptor for hepatocyte growth factor. Now, this signaling regulates important cell functions, and dysregulation can contribute to oncogenesis by improving survival, decreasing apoptosis, regulation of cytoskeletal functions, and so on and so forth. So MET in NSCLC can either be a primary oncogenic driver or a secondary co-driver of acquired resistance in patients with EGFR mutations who've received TKI, as we saw earlier. I'll keep this short. The history of MET spans almost more than 3 decades. Was first found in 1980, and then has been found to be there in multiple tumor types. Was also found initially, the mutations were found in papillary RCC, and there is suggestion that MET does play a significant role in tumorigenic process in a wide range of tumors. So coming to the meat of my topic, MET alterations are basically 3 kinds. MET exon 14 skipping mutations, MET amplifications, and MET fusions. I'll be talking about the mutations and the amplifications. This table shows the two together. So as I mentioned, 3% of patients with NSCLC contain skipping mutations, and out of which 15% have co-occurring MET amplifications as well. Seen in various histologies, mostly enriched in patients with sarcomatoid carcinoma. Again, more smokers tend to carry these mutations, and they're associated with poor survival in elderly patients. Exon 14 mutations also occur independently of other oncogenes and are mutually exclusive, and they're seen in around 1% of patients with squamous cell carcinoma lung. Coming to MET amplifications, less than 10% of NSCLC patients, again seen as a resistance mechanism in EGFR and ALK treatment, seen in all various histologies, notably co-occur with other mutations, and seen quite often in those patients with squamous cell carcinoma who are former or current smokers. So this is a busy slide. The gist of this is basically, and I'll talk about the mutations first and come to amplifications later, is that, so the mutations are a heterogeneous group of mutations, indels, missense mutations. The end result is that they all lead to post-translational modifications detectable at the RNA level. So it leads to, so MET exon 14, that gets skipped. So it leads to a shorter exon 14 splice protein, which has increased stability and hence increases MET signaling. And coming to testing strategies, again, I'll keep it short. So can be detected at the DNA, RNA, and protein levels. IHC usually detects the protein overexpression, but there is a very poor correlation between the IHC positivity and mutations and amplifications, and guidelines do not support it even for screening. FISH is usually used to identify amplification, and it's mostly utilized in select scenarios, mostly when we're trying to find out EGFR inhibitory resistance mechanisms. RT-PCR detects mutations, but the gold standard is next generation sequencing, broad-based panel sequencing, because that detects both amplifications and mutations. And the note point that I would like to mention here is that more mutations are identified by NGS, RNA-based NGS than DNA-based NGS. And you have to be very careful when you're ordering your test, and you have to look at the NGS report and interpret it accordingly. And as I mentioned, guidelines recommend broad-based multi-target testing rather than single drug testing. So drugs targeting MET are 2 types: small molecule TKIs and monoclonal antibodies against MET or HGF. Coming to small molecule MET inhibitors, there are various types. Type 1A, mostly crizotinib. It blocks ATP binding and prevents phosphorylation and activation of the receptor. Type 1B inhibitors, which is capmatinib, tepotinib, and savolitinib, they are highly specific for MET and have fewer off-target effects as compared to type 1A inhibitors. Type 2 inhibitors are cabozantinib, glecitinib, and merestinib. They bind to the adenosine binding site, so they have a different mechanism of action. And type 3 inhibitors, early trials closed for futility. They didn't really work. So crizotinib was one of the first drugs to be studied in the profile 1001. It was a phase 1 open label study, and that included a MET Exon 14 expansion cohort. The overall response rate was 32% and median PFS was 7.3 months. There was no difference in ORR by the type of MET alteration, either by spice site region or by mutation type. Median OS was around 20.5 months. And since crizotinib has poor brain penetration, intracranial efficacy is not that great. Coming to Geometry Mono 1, this was the trial that looked at capmatinib for MET Exon 14 mutated and also MET amplified NSCLC. So there were multiple cohorts in this trial, okay, that's it. I'll quickly run through this. So multiple cohorts depending on the type of mutation or amplification status or the type of therapy, previous lines of therapy. Response rates around 40%, overall response rates in the pre-treated cohort and 68% in the treatment-naive cohort. And intracranial responses were around 54%. Again, no significant difference in response according to the mutation. Coming to tepotinib, the VISION study looked at this again in multiple cohorts. And the point to be noted here is that they use circulating cell-free DNA, liquid biopsy, and they also looked at both amplified disease as well as skipping mutations. So if you look at the update of the VISION study, overall response rate was around 44%. It was almost similar between liquid and tissue biopsy. And response rate was around 44 to 47%. And again, intracranial response rate was around 55%. So again, outcomes were similar between whether you took the mutation based on liquid biopsy or whether you took it based on tissue biopsy. And it was almost similar if you look at the different lines of treatment. Savolitinib has mostly been used in the Chinese setting. And again, multiple cohorts, MET inhibitor naive, MET inhibitor treated, and a confirmatory cohort. Around 21% patients had brain metastasis. So objective response rate was around 30%, and PFS was around 6.8 months. I'll come to the toxicities later, but usually there's a class effect. And again, they had 15 patients with brain metastasis, but didn't really comment on the response rates, but some lesions did show some response. Notably, all these studies, when they took the patients with brain metastasis, a lot of them were already pre-treated with radiation therapy. So that's another point to know. Coming to safety, these type 1B inhibitors, they have class effects, the most common of which is peripheral edema. Nausea is quite common, including vomiting. And another thing is dyspnea. You have to look for ILD. Sometimes pleural effusions may also increase. Edema can be debilitating in a few patients, but is usually manageable with routine management measures. One point to be noted is that LFTs have to be monitored, and patients have to be told about risks of ILD developing. And these drugs are associated with a pseudo-acute kidney injury kind of a picture where serum creatinine rises. That's because of the inhibition of the MET transporters in the kidney. Take-home message here is that if the creat is rising, you don't calculate the GFR, you do a DTPA scan. And if the DTPA is okay, and we do one at baseline also preferably, then you don't really do much about it, you just observe it. So coming to which drug to use depends on a lot of factors: patient preference, toxicity profile, smoking status, regulatory approvals and access, and of course that includes cost. Table just summarizing all the PFS and the OS and the response rates among the three drugs. So I'll skip that and I'll come to this. So I've summarized it in the green boxes. Crizotinib has an overall response rate which is slightly lower, doesn't cross the blood-brain barrier, not really approved for this particular setting. Capmatinib has the highest ORR if you do a cross-trial comparison, 68%, and tepotinib approximately between 48 to 60%. And savolitinib around 40 to 45% in second or later lines of therapy. Out of the potency comparison, capmatinib seems to be the most potent with the lowest IC50. I'll end up in another 2-3 minutes. So in very, very short, Dr. Vijay sir had a talk earlier. Amivantamab is a bispecific EGFR MET antibody that is also being studied. We have preliminary data from the one of the cohort of the Chrysalis trial, and there seems to be some responses, 33% for the entire cohort and 47% for those who did not receive a MET inhibitor prior, and 57% for treatment naive patients. So coming to guidelines prefer capmatinib or tepotinib as first-line therapy, can give crizotinib in certain circumstances, and or you can complete previous therapy and give it in the second line. We can give, so the only thing is, yes, we can give immunochemo combination before we give the TKIs, but then the toxicities increase. So it is always better to probably give the drug, the TKIs first, and then followed by maybe immunotherapy. Similar guidelines, ASCO guidelines say similar things. Coming to MET amplification, just 2 more slides. Small few points about MET amplification. Different FISH criteria are used, either increase in gene copy number or increase in the MET-CEP7 ratio. And each trial that has taken different cutoffs, different kinds of definitions for MET amplification positivity, and that consensus is still not there. So this table summarizes it. If you see profile 1001, there seems to be response rate, but again, some trials are using MET7 CEP ratio of 4 or higher, GCN of more than equal to 10, or GCN of 2.5 in liquid biopsy. So we still have a long way to go. We need more data. All these trials had a small sample size. We have a short follow-up duration. So we need more data. So if you look at the guidelines, they say that MET-targeted therapy in patients with advanced NSCLC with MET amplification can be considered through a trial setting as of now, and can be considered in later lines when patient has exhausted all means or is not really eligible for other treatment. Thank you.
Thank you, ma'am. And